Thank you very much for that introduction, Ashley, and thank you to the network for inviting me to speak about our study. So I'm moving you into the field of substance use treatments, and I'm going to talk to you a little bit about a study that is currently underway in NHS Tayside, supported by the network, and that's a prolonged release opioid for recovery study. So just a couple of acknowledgements and declarations. So this study is an investigator-initiated study funded by Camurus AB, who are the pharmaceutical company who manufacture Buvidal, which I'll go on to speak about in a moment. However, they have no input into the design or the implementation of the study, and indeed will have no input into the analysis either. And I'd just like to take this opportunity to thank the participants who are currently engaged with the study, and hopefully more that will join us, because really without them sharing their experiences and their views and thoughts, we wouldn't be able to do the study. So because we're moving into the area of substance use, and I know everybody here doesn't necessarily work in that field, I thought it'd be helpful to provide some context to the situation within Scotland. So we know that drug use disorder is the 6th leading cause of early death in Scotland, and we know that it really affects our deprived communities. So people in our deprived communities are 16 times more likely to experience a drug-related death than those in our least deprived communities. And it really is a wide-reaching problem right across Scotland. So 1 in 60 of our population experience problematic drug use. So that's problematic drug use. I'm not talking about recreation drug use that somebody might use, on the odd occasion. This is problematic drug use that has a significant impact on their daily life. So putting that into figures, that's 57,300 people. So you're starting to get an idea of exactly how widespread this is. And really it is a national shame, drug-related death and the impact that it has in our communities. So last year we lost 1,051 people to accidental, avoidable drug deaths. So this isn't people that have taken substances with the intention of ending their life. This isn't people that have been intoxicated, got in a car, into a car crash and died. This is people that have had an accidental overdose. And last year was the first year in a very long time that that figure decreased, so it has been steadily rising. We know that there's rising harms, both physical harms and social harms, to individuals and our communities right across Scotland. And recognising this, the Scottish Government have really had a huge focus on substance use and established the Drug Death Task Force back in 2019 to start to identify some evidence-based strategies that we could implement here in Scotland to try and turn around this tide. And there were 6 key work themes for the Drug Death Task Force, and one of those is in medication-assisted treatment standards. Now, if you work in the field of substance use, you will know them back to front and inside out because it's been an absolutely massive focus for our work. But if you're not in that area, I won't go into all of them. There are 10 of them, but just giving you an idea of some of them. Standard 1 is somebody turns up, and on that day that they turn up and say, I've got a problem, I need help, they need to get that help. So they need to get onto treatment, to be offered treatment on that day 1. So reflecting back to Sharon's talk just before lunchtime, you can think how much of a change that is for NHS services to be able to deal with that kind of demand. Standard 2 is that treatment options should be available to all patients. All treatment options should be available to all patients, and patients really have to be right at that centre and be able to make informed choices as to what they want to receive. And to back up that Drug Death Task Force, the Scottish Government implemented a national mission, and that covers the period 2022 to 2026. And that is really focusing on making sure that people have rapid access to quality treatments right across Scotland. So as I said, our study is based in NHS Tayside. So just to give you a little bit of a flavour of the scene within Tayside, we have 3 drug and alcohol partnerships within our health board region. So we have Perth and Kinross and Angus, fairly similar kind of size of population for us as a treatment service, made up of some cities, towns, but a lot of very rural areas as well. And then we have Dundee City. So Dundee City has the really awful title of the drug death capital of Europe. So really lots and lots of challenges within Dundee. Drug services are delivered by NHS services, supported by a lot of third sector organisations. So we work really closely with them. So organisations such as We Are With You, Hillcrest, Positive Steps, Aberlour, lots and lots of services that some of you may be familiar with. Public Health Scotland estimates that within Tayside region, we have about 4,600 people experiencing problematic drug use. Now, not all of those people will be opiate related, so it does include the estimates, things like cocaine, cannabis, benzodiazepines. But certainly a lot of them will have an opiate dependency. And within our drug treatment services right across Tayside, we have roughly 2,000 people currently being prescribed opiate substitution treatment, which I'll just refer to as OST from now on, just for ease. Now, we know that people who use drugs experience shame and stigma. There's a wide range of literature that describes that, and our patients tell us that as well. They experience shame and stigma from the wider community, but they also describe feeling that from healthcare services as well. People who use drugs are often considered to kind of be acting outside the social norms of society, and because of that, they're excluded. They're made to feel like second-class citizens and often feel like they have a tainted identity. And one of the consequences is that people feel like they are deprived of choice, of options, and inclusion. I'm going to move to talk about opiate substitution therapy. So thinking about that 2,000 people that we've got on OST within Tayside. So OST, it's been the mainstay of pharmacological approaches to opiate dependency in the UK for many, many years. It is very, very well evidence-based. So I would imagine all of you are familiar with the terms methadone, possibly less so familiar with buprenorphine, although we've had it for a long, long time. So until fairly recently, that was just as a sublingual tablet or an oral lyophilizate. So it's either on or under the tongue, just dissolved there. And the vast majority of our patients receive these medications on a daily basis. So they'll either have to go to the pharmacy every day and pick it up, or what's actually more likely is that they actually have to have supervised consumption. So they'll have to go to the pharmacy, wait in a queue, be taken into a private space, a consultation room, and they'll be observed taking this medication. So we create a really controlled environment for this particular patient group. And the way that we deliver OST, quite rightly, is subject to a lot of criticism, because actually we make it really difficult for people to make the desired changes that they need to make. And actually, we make it so difficult for them to make those changes, because if you think about having to go into the pharmacy, patients tell us, I feel stigmatized, I feel judged. They feel judged from other people using that pharmacy. They think that people know why they're going into that room. They feel judged by the healthcare service as well. And also it makes it really difficult to fit in daily life around that. I don't know how I would attend a pharmacy every single day and hold down a job, take my kids to school, education and things like that. So it's a big problem. Now in 2019, we've got the new kid on the block. So it's still buprenorphine, but it's a subcutaneous prolonged preparation. So the only licensed prep available at the moment in the UK is Buvidal. So I will just refer to it as Buvidal at the moment. And this is given as either a weekly or a monthly injection. So generally, patients will receive a weekly dose. They'll probably get 4 of those, and then we'll move them on to a monthly injection. So that gives that patient a lot of flexibility. So they're not having to go to the pharmacy every single day. They just haven't come in for their appointments and to get the injection. And actually, COVID-19 did us actually quite a big favour when it came to Buvidal, which is quite bizarre thing to see, but it really forced our hand, because we were looking at mechanisms to decrease the amount of social contact for our patients in the prison setting, but also within our drug treatment services in the community. And Scottish Government funded the implementation of Buvidal, so we rapidly got a lot of patients onto Buvidal. And we could see that actually this could potentially address some of the criticism levelled at the way that we currently deliver OST. It's going to give that person a lot more flexibility. They're not going to have to go to the pharmacy, and they're not going to have to feel that stigma of having to go somewhere every single day. So we started to think about that a little bit more, thinking about kind of that controlled environment, having to go to the pharmacy. And if you think about going into the pharmacy as well, you're not just the only one going there for OST. There are likely to be other people also going there that perhaps aren't as supportive of your recovery journey as you would wish. So our patients definitely tell us that there are individuals also attending the pharmacy that they'd rather avoid, perhaps due to past histories. So we started to think about that situation and looked at some of the work around about the social identity model of recovery. Now, this is David Best, who's based down in Sheffield Hallam University, does a lot of work around about the social identity model of recovery. And that kind of chimed a little bit with this morning's presentation talking about identity and social networks. So your self-identity is shaped by your social network, and we definitely see that's true within people who are using drugs. So they'll tend to have a lot of other people within their social network that also use drugs because that's a social norm of that particular social network. And we know that when people are moving into the initial stages of recovery, then the importance of the active using network is quite high, whereas the importance of non-using groups and those in recovery tends to be a little bit lower. And then we start to see that tip, that we see patients starting to distance themselves slightly from other people that are using drugs, and then that continues, so it eventually tips the scale. So we've got more people in their network that are more supportive of that recovery journey and provide a lot of support for that, so build that recovery capital. So we started to think about this in relation to Buvidal, and this is where the PROP study came from. So there is some evidence when they first brought Buvidal to the market that patient perceptions were that this would give them a lot more flexibility. They could avoid the stigma of having to attend a pharmacy every day to get their OST. And because it was delivered as a subcutaneous injection, there was that kind of reassurance for services about the community safety aspect. So we knew that we weren't going to have controlled drugs leaking into the community and putting others at risk. So absolutely, for some people, they could identify that reduced attendance at the pharmacy, great, I'm not going to have to bump into Jimmy, who possibly will offer me some drugs when I'm having a really bad day and actually might be tempted. Things like I can go on holiday without having to ask for permission, which seems like such a bizarre thing for us standing here to think, actually, I've got to ask somebody for permission to go on holiday, but take my medication with me. But that's a daily reality for our patients. And it's just things like education, employment. If you've got young children, if you've got to drop them off at school, you've then got to go to the local pharmacy where the other parents are wandering by, or perhaps in the pharmacy as well, making judgments about you. So all absolutely great reasons for not attending the pharmacy. But we also have a group of patients where actually that might be a disadvantage. So if we think about our patients whose routine is based around attending the pharmacy on a daily basis. So actually, we do have patients that say to us, if I wasn't going to the pharmacy, I wouldn't leave the house. So where is that routine? For patients who are really unstable, if there's an increased risk of them having an overdose, or if we're worried about their mental health, at least we know that there's a safety net that the pharmacy is going to see them on a daily basis and will flag, we're worried about such and such, it's not presenting as usual, it's presenting intoxicated, looks a bit disheveled, and that's that early warning for the services. So if we take that away, how do we kind of replicate that within the community? And actually, a lot of the studies so far looking at Buvidal have looked at safety, retention, so keeping people in treatment and abstinence from other illicit drugs, but they've not really focused on the social value. So what does it mean for patients? What does it allow them to do within their lives that they wish? And how does that impact on their recovery journey? So that's what we're trying to do with the PROP study. So our primary objective is we'll look at that social network change. So thinking back to that social identity model of recovery. So we're going to do some mapping of that. We also want to understand of how that improves somebody's well-being and that kind of holistic gains. What does it allow them to get on with in their life that they wish to do by delivering opiate substitution therapy in a different way? So what are we going to measure? So over the course of 18 months and at 3 different time points, we are going to look at patients. So we've got one arm which are receiving Buvidal, and we've got a control arm, those that are receiving methadone or the oral buprenorphine preparations as standard. And then we have a kind of a separate arm to that. We have staff participants. So actually, it's really important that we get staff views because they're having to deliver this and treatment in different ways. So we're getting those views as well. So we're doing a bit of both, so qualitative and quantitative. So qualitative, semi-structured interviews. I'll give you kind of a flavour of some of the questions just in a moment. So that's both patient participants and staff participants. We're doing some social identity mapping, and again, I'll show you that in just a second to try and categorise that change in social network. We're using the Short Work Edinburgh Mental Wellbeing Scale. I know some of you are familiar with that because I did spot it on a poster that somebody's also using it. So I'll give you a flavour of some of those questions as well. And we're also trying to capture financial inclusion data. So we're using the core Scottish census survey questions around about accommodation, employment, education, financial inclusion. So how comfortable does somebody feel financially? Are they struggling to pay bills? Things like that. Now, our patient participants are incentivised, so we do reimburse them for their time using supermarket vouchers, which I think is right. Staff, unfortunately, don't get the vouchers. Unfortunately, we weren't allowed to give them vouchers, so just part of their day-to-day activities. So just to give you an idea of some of the questions, I won't go through all of them, but some of the questions that we're asking people. So we're asking them to reflect on drug use and how that has impacted their life in the past. How are things now? And then what are they hoping for the future? We then get them to think about being on OST. So some of our participants, for example, who are on Buvidal, it's only been available for a short time, will have had experience of other OST preparations as well, so they can kind of compare and contrast, although we do have a few in the Buvidal arm that have gone straight onto that. And the other one that I want to point out in particular is around about the relationship with the key workers. So I think this is really important to capture, because prior to having Buvidal, their key worker appointments were very holistic and was talking about their goals and what they needed to support them. And we were delivering the OST outside of that. So it was done at the community pharmacy. For Buvidal, for a lot of services, we've now moved Buvidal into that appointment time. So that appointment then kind of changes the focus. So is it still on that holistic, or are we now focusing too much on the delivery of the OST and actually missing out on some of that kind of holistic wraparound care that patients need? So we're asking questions about that for both staff and participants. I mentioned the short work Edinburgh mental wellbeing scale. So if you've not seen it before, it's 7 statements, and then the individual rates where they are on that scale. That gives you a total score. And movements in that total score are validated so that you can see, well, this patient or this population have moved X amount, and that would have cost us X to get an equal improvement in their well-being. I think that's really, really important, particularly for Buvidal, because it is putting pressure on drugs budgets right across Scotland. So if we can prove that actually it is improving people's well-being as well, then that gives us a lot of backup to be able to can make those financial arguments for it or not. This is the social identity mapping tool. So again, this is based on David Best's work, and it's kind of a similar map to they've used. So you would put yourself in the center, you're in a circle, you would write the names. So it is a pseudo identity. So I don't ask for people's full names. It might just be mum, best friend, Paul. So I wouldn't be able to identify them, but the participant can. And then they'll categorize them. So do they actively use drugs just now? Are they a non-user, or are they in recovery? And then on the outer circle, it'll be that kind of more kind of separate kind of social network. And we will do that each time. So we'll hopefully be able to map how that social network changes. So what we're hoping to do is a thematic analysis of that qualitative information and triangulate that with the quantitative data. So we want to be able to describe the real world outcomes for patients. So if patients in the qualitative interviews are telling us it's great, I'm not having to go to the pharmacy for my Buvidal, I don't have to meet those acquaintances that are possibly not so supportive of my recovery, we can back that up with a social identity mapping tool by saying, actually, yes, we can see that actually that people that are actively using drugs are becoming less important within their network. And really want to capture the views and the meanings and the value that patients who are receiving treatment view it through, and again, provide that reassurance for the additional investment that it is costing. So as I said, this is a work in progress. So we have recruited all of our Buvidal arm and are progressing with the second round of interviews at the moment. The staff arm is fully recruited and the interviews are complete. The control arm has been more challenging, and I think that's probably actually just a reflection of human nature. When we get something new, we're actually quite keen to talk about it and share our experiences, where if it's something that you've been on for a long time or it's been around for a long time, you're probably less likely to want to kind of share your views on that. I have to say the network support has been really key to that. So Tessa's been working with us and being able to share actually her experience of being able to recruit for this patient population. It's not easy. Quite a lot of our patients change telephone numbers frequently. If you work in the field, you'll know that. And our ethics put on a condition that we can only phone them twice, regardless as to whether or not they answer the phone or not. So that makes it quite challenging for recruitment, but we are making progress. So hopefully we'll be fully recruited soon. So I'm aware I'm standing between you and a cup of coffee, so I'll stop now and happy to take any questions or chat over a cup of coffee.
Thank you. Yes, it's really great to hear about a study that tackles stigma and tries to make things a bit easier for people day to day. So yeah, thank you. We did start 10 minutes late, and we're probably slightly over now. We have one question online. Okay, can we do that quickly? Okay. Can Transtech transdermal buprenorphine patches be used in a similar way to Buvidal, or is the study limited to the injection? Does Buvidal taper doses reducing over the time to reduce opioids withdrawal?
Okay, so first of all, the transdermal buprenorphine patches are not licensed for use in substance use disorders. The doses are much lower and it's used for pain, so no, we wouldn't use transdermal in that way. And tapered doses, so yes, we do have patients who've done very well on Buvidal who are now tapering down their doses. We can get them to so far, and then we're having to kind of look at potentially switching them back to oral buprenorphine for a very short time, just to support the end of that tail off. But yes.
Okay, thank you. And there's one more question from the back.
Okay.
I can hear you.
Psychiatrist in Fort Valley, and we've got like 200 people on Buvidal. It's a great thing. Yeah. The problem is the drug deaths have partly been increased through street benzodiazepines. Yeah. So what are you doing about people on Buvidal who are also chaotic benzo users? And if you do prescribe benzodiazepines, are you still making them go to the pharmacy every day, which is what we're doing?
Yeah, so I think that's a very good question. Actually, I think it's probably actually a little bit wider than benzodiazepines as well. So particularly I'm thinking about the gabapentinoids, where previously if somebody is attending a pharmacy for their methadone, oral buprenorphine, so other prescribed medications that increase their risk of overdose, so antidepressants, gabapentinoids, we would tend to mirror their dispensing. So somebody would have to pick them up on a daily basis. Now, clearly, if you remove them from the pharmacy, there's no need for them to go to that pharmacy on every single day. However, I think we are still continuing with that daily dispensing at the pharmacy because actually the risk is still there. And certainly there is, I guess the question is if you do put somebody onto Buvidal and they can no longer use opiates on top, actually do they tend to use more benzodiazepines if they actually haven't addressed that underlying trauma? So I think that's a question that we actually need to examine. And I know that long-term prescribing benzodiazepines is quite a controversial topic in Scotland at the moment, but hopefully we're going to get some national advice around about that.
Thank you. In the interest of time, we're going to leave for the break now. Can I ask everyone to come back at 4:05, and don't forget to vote for your favourite posters because we'll have the poster awards results after the break. Thank you.